The most recent advances in the pharmacological treatment of schizophrenia can be divided into those that are already around, for example, in the United States and might come to other areas of the world, and things that are still in development. Let me start with the first component, and that is looking at lumateperone, for example, which is a novel antipsychotic which blocks postsynaptic dopamine receptors but stimulates presynaptic dopamine receptors and gets away with 39% of postsynaptic dopamine blockade. Very little side effects that we know from other dopamine blockers or partial agonists, and it also has an SSRI built into it, approved now for bipolar depression and unipolar depression. Might help people with schizophrenia who have comorbid depressive disorder or maybe negative symptoms. Stay tuned. And there's also a deuterated form of it that is being developed, which is ITI 1284, which might be developed as a long-acting injectable. Other treatments not yet available in most parts of the world is Olanzapine with samidorphan, which is a new opioid-preferring opioid antagonist, which reduces appetite and satiety and therefore after a lag time of 4 weeks or so reduces weight gain with Olanzapine. Another treatment for side effects is the area of VMAT2 inhibitors, vesicular monoamine transporter 2 inhibitors. What are these? They package the neurotransmitters that have been released into the synaptic cleft back into vesicles presynaptically. And by blocking that packaging, there is less stimulation of postsynaptic dopamine receptors, which then can lead to a reduction in tardive dyskinesia symptoms. But guess what? Since it reduces presynaptic dopamine, it has also been tried as an augmentation treatment of dopamine blockers for people with residual positive symptoms. It didn't work for total symptoms, which was the primary outcome, but it did work for positive symptoms. So maybe in the future, when we have different VMAT2 inhibitors like deutetrabenazine and valbenazine that are not yet available, they could be used as augmentation of dopamine blockers. What about the most recent advancement? Well, it's the cholinergic system, xanomeline, trospium. Xanomeline, an M1, M4 muscarinic agonist. Well, I don't have time to go through all of the pathophysiology, what it does, but ultimately it converges on reducing presynaptic dopamine output. Presynaptic, not postsynaptic. And since it can spill over into the periphery, we can have procholinergic side effects, GI side effects, nausea, vomiting, and in the past even syncope. Now paired with trospium, chloride, which is a postsynaptic, or peripherally I should rather say, restricted anticholinergic, these symptoms can be buffered. Approved for schizophrenia, total symptoms, was tried as augmentation in people who had residual positive symptoms, didn't work for total symptoms in everyone, but in those not treated with risperidone, it did work, and in the entire group it worked for patients who had positive symptoms, and therefore it worked for positive symptoms. What are other treatments that are in development? There was Ulotaront, a TAAR1 agonist. TAAR1 agonism can reduce positive symptoms. Again, presynaptic treatment. It worked in phase 2, it didn't work in phase 3, but another study is ongoing, and Ulotaront is also tested right now for GAD and augmentation in depression. What else is around the corner? Well, we've seen in terms of available treatments, subcutaneous long-acting injectable treatment for risperidone, and now there's a development for subcutaneous olanzapine as an LAI. That's relevant because the current intramuscular olanzapine has the so-called PDSS, post-injection delirium sedation syndrome, which can really decrease breathing and can be potentially fatal. 1 in 1100 injections. This will not happen with a subcutaneous injection because it's not as well perfused, and also it is a copolymer that doesn't really go into the bloodstream, or it's not dissolvable as much as the olanzapine palmate, the intramuscular injection. What else is around the corner? Amisulpride, much known to many outside of the US, a benzamide antipsychotic, has the problem it doesn't penetrate the blood-brain barrier very well. It stays outside, can increase QTC, can also increase prolactin. Guess what? When you N-methylate it, it goes through the blood-brain barrier nicely, and a phase 2 study, soon to be published in JAMA Psychiatry, has shown that instead of 600 to 800 milligrams for psychosis needed with amisulpride proper, with the LB-102, which is N-methylated amisulpride, you can get away with 50, 75, and 100 milligrams and have less peripheral side effects. This is now being developed for phase 3, and most recently, I think actually today it was announced that it's also studied for bipolar depression, because amisulpride has a right-turning stereoisomer, which is a 5-HT7 antagonist. So it's been used also in some areas of the world for dysthymia, approved, and at low doses worked for negative symptoms in schizophrenia, like antidepressant added to antipsychotics. You can treat negative symptoms. So here we may have another treatment that can help patients with potentially negative and positive symptoms. And finally, treatment resistance. Very hard to treat, only clozapine is available. Here Evenamide is being tested, and Evenamide is a state-dependent sodium channel inhibitor, which then decreases glutamate when glutamate is being driven up as a response to stimuli. So that's in the making, but we also have different domains, don't we? We have cognition. Here we've had failure with eclapertin, which was a glycine transporter 1 inhibitor. We also had failure with luvadaxistat, which decreased the breakdown of D-serine, all co-agonists on the glutamatergic system. But xanomeline has shown some promise in the treatment of schizophrenia, but only in the acute phases. However, the M1 stimulation might increase dopamine and glutamate prefrontally. In the whole muscarinic class, we have a big development for psychosis, and maybe also looking into psychosis associated with Alzheimer's, even mania. And here other treatments than xanomeline are tested. Direclidine is one trial that is in phase 3 right now. MAPLIGHT 007, ML007 is being tested, and also emraclidine, which had a positive phase 1b study, didn't make it in phase 3, is being recalibrated with higher doses. So stay tuned for the muscarinic area, which I think will also really burden and create different treatments for us. In the other area of negative symptoms, there's only one agent currently in the running, and that is roluperidone. Phase 2 was positive, phase 3 was negative, and we'll see whether they'll conduct another phase 3 study. So you see, lots of things are ongoing, hopefully also spreading from the US, where some of these treatments are already approved, to other areas of the world, and hopefully bringing us even new medications with new mechanisms of action to help our patients to reduce symptoms and also achieve better outcomes in terms of functionality and quality of life. Stay tuned.